We lopen mooi op schema en dat komt goed uit. Want dat wil zeggen dat we het komend kwartier tijd hebben voor een mooi tweegesprek. Hier achter mij zien jullie een interviewsetting, zoals we dat heten. En ik ga 2 dames het podium geven. Veel dames vanavond trouwens. Leuk om dat ook een keer mee te maken. Zij komen al naar voren. Dames en heren, Jolanda Sinha is hier van IKNL. En Caroline Berchet. Mag ik voor beiden een groot applaus. Kijk. Jolanda, ik begin nog even in het Nederlands bij jou. Want Jolanda, je bent woordvoerder bij IKNL. We openen deze avond met de mediastorm die jij vandaag als woordvoerder hebt veroorzaakt. Je vertelde me toen we elkaar vanavond zagen dat ruim 8 miljoen Nederlanders, ongeveer dus de helft van de Nederlanders, hebben vandaag kennis genomen van dat nieuws. Heel belangrijk om dit te laten landen. Leef je nog?
Ja, nog even. Morgen is...
Nog even? Nou, wacht even. Morgen ben je er ook nog, toch? Ja. Dit klinkt een beetje als dat je nu je levenswerk hebt voltooid. Maar je hebt echt iets heel belangrijks neergezet. Maar je zit hier niet als woordvoerder. Want je zit hier omdat je portfoliohouder internationaal bent bij IKNL. En dat brengt me tot jou, Caroline Berchet. Welcome here with us from the OECD. We're going to switch to English now. Because, of course, obviously, you're from France.
Yes.
Welcome here with us. Bonsoir. The floor is yours. Succes.
Thank you. Thank you. Yeah, so I switched to English, and I'm here with Caroline Berchet from OECD. It must be a challenge to be in this all-Dutch event.
Thanks.
But, of course, the results that are presented are quite familiar for you. So you work for the OECD, the Organization for Economic Cooperation and Development. I think not everyone here in the audience knows what OECD is. So maybe you can tell us a little bit about OECD and your responsibility and your role there.
Sure, thanks a lot for the invitation. It's a pleasure to be there, and congratulations for the good work. So I'm Caroline Berchet from the OECD. I'm a health economist. So the organization aims to benchmark, the performance in different topics. So I'm working specifically on performance of oncology care across EU countries and OECD countries. So for this project specifically, we are developing a cancer inequalities registry in collaboration with the European Commission and the Joint Research Center. So the objective is to benchmark countries using a lot of data covering all pathways of care for cancer. So from prevention to access to early diagnosis, access to oncology medicines and treatment, to quality of care.
Yeah, so and you collect all these data, and I know that at IKNL we also support you in getting the data for the Netherlands. And then you make these country profiles, right? So what are that?
Thanks. So yes, for the cancer inequalities registry, the OECD produce different outputs. One of them is a series of EU country cancer profiles that you can see in pink in this slide. So the objective of the profiles are to identify trends in cancer prevention and cancer control across countries. So we look specifically at 29 EU countries, so the 27 member states plus Iceland and Norway. Using the data from Eurostat, the OECD Health statistics, but also national statistics that are sent by our experts, we compare the performance. So as I told you, for each country, we will look at the cancer burden in the country, the risk factors for cancer, and the ongoing prevention policies that are implemented in each country. We present early detection program in the country and trends over time. And lastly, we present an analysis of cancer care performance, so looking at accessibility, quality, cost, and in 2023, we had a specific section on the impact of COVID-19 pandemic. Now we will have a new series in 2025, and we will have a specific focus on quality of life for people living with cancer. So the objective of the profile is really to identify inequalities across countries, but also inequalities within countries by population groups.
Okay.
I want to mention as well that in addition to the quantitative data from OECD statistic, Eurostat, and the national statistic, I want to highlight that we conducted several interviews, more than 40 this year, to reflect the specific context in each country. And this is important because we are working with experts to understand the context and to highlight the main challenges. The overarching idea is to focus on policy implication, to provide recommendation for policymakers to address these inequalities.
Okay, so these country profiles really, I can imagine that you see a lot of inequalities between countries, but also within countries like we're talking about today. So do you also take into account the socio-economic factors in your reporting?
Yes, so we have some limitation with the data, but let me show you some of the main results, overall results from this work. So, two messages. The first one is that we see in Europe that the burden of cancer is increasing, cancer incidence is growing, and is expected to continue to grow by 18% on average in the European Union. And we can see that there are marked inequalities. So, in 2022, cancer accounted for 1/4 of all deaths in Europe. So the human impact of cancer is large in Europe. As you can see in this graph, so it shows age-standardized cancer mortality rates, and we can see that there is a twofold variation in cancer mortality across Europe. So the likelihood of dying from cancer is not the same in this region. So this is one finding. A second finding, which is a good news, is that countries are making progress in reducing cancer mortality. So this is true in mostly all countries. So in 27 countries, we can see reduction in cancer mortality over time. And the good news for you, in Netherlands, we can see that the reduction is higher among both men and women than in the EU on average. The second key finding of all this work is that looking only at averages misses the point, because we see that there are large inequalities by population groups. So first, by gender, as you can see here. So it's the same age-standardized cancer mortality rates, but with a breakdown between men and women. So you can see that in all member states, plus Norway and Iceland, inequalities by gender is large. This is one important thing. The second important thing that I want to show is that the variation across countries is much higher among men population. So this means that if policymakers want to reduce inequalities across countries, health intervention should focus on the men population first. This will first reduce inequalities. And in Netherlands, we can see that the country displays one of the lowest gender disparity in cancer mortality. So this is a good performance alongside some Nordic countries, Sweden, Iceland, Denmark. In Baltic countries, unfortunately, we can see that the gender disparity is the largest. And then we can see that there are some socio-economic inequalities in cancer mortality. So these data have been published in 2022 and 2023. New data will be published in 2025. So for now, we don't have the data for Netherlands. But here, among 15 EU countries, you can see that in most EU countries, we have social gradient in cancer mortality by education level. So people with low education are represented by the black dot, and the high education people are represented by the white dot. You can see that inequalities are larger among men than women, first. And we can see again that the variation across countries is much higher among people with low education. This means that if we want to reduce inequalities across countries and within countries, we should target low-educated people, those living in most deprived areas, those having low income. So for Netherlands, as I told you, we don't have the data yet available, but national studies, as we shown previously, clearly are in line with these findings, showing large inequalities.
Yeah, so I missed Netherlands in this slide. So I was wondering, so compared to other countries, do you think that the socioeconomic differences in Netherlands are average? Are they larger or smaller than average in Europe?
No, from the work that we can see, Netherlands is among the good performer among the EU countries. Indeed, it will depend on the outcomes that you use for measuring socioeconomic inequalities. As you know, we can use education, we can use income, you can use at ecological level the deprivation of the geographical area, and you can use as well migration status. But overall, I will say that the level of socioeconomic inequalities is lower among Netherlands than other EU countries like in eastern or central part of Europe. Okay, but so indeed, there is not the same level of development as well, and not the same policies implemented.
Yeah, so at least some good news today.
Exactly.
But
it doesn't mean that Netherlands don't want to progress, of course.
Yeah, so that was my next question, actually. So what can we learn from other countries, and what is things that Netherlands should do?
Mm-hmm. So as I mentioned previously, we look at different areas through the pathway of cancer care. Prevention, early diagnosis, but also quality. There are three main dimensions that will have an impact on inequalities. So let me just show you some broad recommendation for Netherlands, but it applies to many other countries, obviously. The first one is to improve prevention and early death and public health intervention. As you know, nearly half of cancer deaths in the Netherlands are attributable to non-cancer risk factors. So this is a finding that is common across all EU countries. It's around 40 to 50% of cancer deaths attributable to risk factor. As you can see in this dartboard, Netherlands is doing well in the majority of risk factors. So you can see the dot in the green area. It means that the prevalence of smoking, the prevalence of alcohol consumption, of overweight, of low physical activity, or occupational exposure are lower in Netherlands than in other EU countries. So again, a good news. But the bad news is that you can see large inequalities in some risk factors in Netherlands compared to other EU countries. So this is one example for smoking. As you know, smoking is the first preventable risk factors that explain cancer deaths. And here, we show the prevalence of smoking across EU countries by income level. So we see on average a gap between education group, I would say. But in Netherlands, the prevalence of smoking is 3 times higher among people with lower income than higher income. Now, as you can see, the gap is quite large compared to other EU countries. So this is one big recommendation for the country to target the low income group on the prevention side. There are other risk factors that we look at in this profile, notably overweight and obesity. As you know, it's a growing issue in all countries. Again, in Netherlands, it increased over time, and in 2022, it will be shown in the forthcoming profile, but in 2022, nearly half of the population is overweight and obese, according to European Health Interview Survey. So this is huge, and we can see large inequality among women in disfavor of low-educated groups of women. So again, we need to improve prevention for the disadvantaged population groups. We know what to do. It's about cancer awareness program. It's about public health intervention in primary health care. It's about school-based intervention. It's broader fiscal and regulatory measure. But clearly, we don't do enough. In 2022, the share of health spending devoted to prevention is around 6% in Netherlands, so it's low. Still, it's higher than the EU average, which is around 3.5%. But 6% of health spending is devoted to prevention. This is low.
Yeah, that's a strong recommendation. And you're mentioning smoking, eh? So we recently also had a report on smoke prevention, and we calculated what it means if we really stop smoking in this country. And that will save like 120,000 cases of cancer in the coming years.
Yeah.
So, but at the same time, we see that youngsters are more attached to smoking now with the vaping. So that's an important risk factor that is really cause to many avoidable cancers. So this is a very strong recommendation that also here, I know that there are policymakers here. Really, we should focus on that, and I think you will enforce this with these figures. So, any other recommendations for us?
Yeah, I have many. So the second big recommendation, of course, it's about accessibility. So I will only focus on accessibility to screening programs for breast, cervical, and colorectal cancer. So this will be published in 2025, around February. It's under embargo. But we look at trend in participation rates for so breast, cervical, and colorectal cancer screening program. It's based on program data from your cancer registry. And it has been validated by experts. But you can see that from 2005 to 2022, participation rates for the 3 screening programs are declining. So it has been exacerbated by the COVID-19 pandemic, of course, as in many countries. But even between 2021 and 2022, we can see a further decline.
These are figures for the Netherlands only,
Exactly, only Netherlands. So clearly, one key message is to improve access to screening programs for the whole population. So this means improving the financial accessibility, the geographical accessibility, and the cultural accessibility. Because national studies in Netherlands also show large inequalities in access to screening programs by education, income, or migration status. And this is shown quickly in this graph. So it shows the participation to cervical cancer screening programs by education level across countries. So it's based on European interview survey, so it's self-reported data. So we know there are some biased, but at least it's comparable across countries. And here we can see that in all countries there are large inequalities by education level for access to cervical cancer screening. It's also the case if you look at breast cancer screening program and colorectal cancer screening program. So this is a strong message. Policymakers need to improve on average the participation, but also to work with the most disadvantaged population to make sure they have access to the program.
Yeah, so this is actually a part of the explanation why late diagnosis in these groups occur, right?
Exactly.
So, yeah, that's something that we have work to do. So we have only
2 minutes left.
2 minutes left. So
okay, I will be quick then.
Yeah, so last recommendation.
Last thing that I want to focus on is on improving quality. So quality of care, but also quality of life for people living with cancer. So another good news is that we show in our report that the Netherlands provides very good quality of cancer care compared to other EU countries. So the best indicator to measure quality of cancer care across OECD countries or EU countries is to use the survival estimates. So using international data from Concord program, we can see that for the main cancer type, prostate, childhood leukemia, breast cancer, cervical cancer, colon cancer, and lung cancer, the 5-year survival rates are higher in Netherlands than in the EU on average. And new data from the cancer registry show improvement over time. So this is very good, and it's mainly based because of very good policies, multidisciplinary team, establishment of cancer network, use of guideline, comprehensive cancer registry, clinical audits. These are all policies that not all countries have implemented in the past year, and it's a very good example. Now, with increasing survival and combined with increasing incidence, we can see that the prevalence of cancer is increasing in all countries, including Netherlands. So it means that cancer is becoming a chronic disease, having a high impact on the quality of life, on income for people, and we can see that there are large impacts on the mental health of people. So on the quality of life and well-being, the OECD projection show that in Netherlands, cancer will cause an additional 14 cases of depression per year over 2023-2050. So this is close to the impact in the EU average, but clearly it needs that now countries should invest in policies on quality of life, survivorship program. So psychological support, rehabilitation, economic reintegration, right to be forgotten, and so on and so forth. This is a big recommendation as well.
I think this resonates with many of us here in the audience here. So, yeah, we have to conclude our fireside chat. There's no fire, but it was we have a nice setting here. So, for the future, you at OECD are really monitoring these disparities and benchmarking between countries. So what do you need from us to do your work better?
So first, to continue the collaboration, because we need you, experts, to build our work, to have the context in each country, to have the national estimate. This is very important. So I will say to continue our collaboration, continuing to have interviews that provide very good insight, input to this work. And the second one is to improve measurement, because this is key to improve, to reduce inequalities. We need to monitor performance, we need to benchmark with other countries to know, what works, what does not work, and to improve, to have a continuous improvement cycle, I would say. So today, as I will show in my last slide, we only measure regularly at international level the indicators that are in blue. So it's about half of the data. The other half, we don't have it at the OECD. So we need to work continuously with all Ministry of Health to make progress in the measurement. So this concerns patient-reported outcome measure. It's key today to have it and to develop it, but also some resources, basic resources. Oncologists, radiologists, spending for cancer care, we don't have good international data.
All right. Thank you so much. It was such an honor to have you here on stage and
Thanks a lot.
explain.
Maybe as a teasing, the new concept profile will be out on February 2025.
Okay.
All right. Thank you very much. Jolanda Sinha and Caroline Berchet. Thank you so much for joining us here today. Dames en heren, het is tijd om dit gedeelte te wrap-uppen, zoals dat dan heet. Het viel mij op aan het verhaal dat gelukkig de kwaliteit, maar dat weten jullie al veel beter, al veel langer dan ik, dat de kwaliteit van de kankerzorg in Nederland heel erg goed is. Sterftecijfers zijn aan de andere kant vergeleken met de EU-landen op sommige fronten hoog, met name dus bij mannen en ook bij mannen met een wat lagere sociaal-economische status die roken. Ik zat aan Johan Derksen te denken, ik weet niet of dat ook uw gedachte was. Ik wil ook niet per se dat beeld nu op uw netvlies brandt terwijl we zo meteen pauze gaan houden. Maar er is in ieder geval werk aan de winkel en tijd om ook aandacht voor de mannen te hebben. Dat vond ik op zich wel positief om er in ieder geval even uit te lichten. Voor de rest gaan wij zo meteen verder met het programma. Straks na de pauze dan gaan we verder praten over hoe we gezondheidsverschillen kunnen verkleinen. We hebben 3 inspirerende voorbeelden voor je meegenomen. En we gaan nog in discussie, of in dialoog moet ik zeggen, met Kamerleden over Health in All Policies. Dat belooft veel goeds. We hebben 17 minuten pauze, zie ik. Die gaan we goed gebruiken. Als jullie zo meteen om 7:30 terug zijn, dan loopt het programma geen vertraging op. Dus tot zometeen, tot 7:30. Dankjewel.